Support Microbe TV. It's time for our annual fundraising drive. We depend on your support to produce high-quality science videos and podcasts, and now is the time to help us. If our programs have appealed to your science interests, or if they have helped you in some way, please record a brief audio or video with your phone and tell us about it. Let us know how we empower your inner scientist. We'll use it for our fundraising efforts. Send it to incubator@microbe.tv. And for more information on how you can give us your support, go to microbe.tv/contribute.
From Microbe TV, this is Infectious Disease Puscast, episode 69, recorded on Friday, December 6th, 2024. Hi everyone, I'm Sara Dong. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. You have just me today. Daniel is off in Africa, but he will be back for our next episode. Got plenty of interesting papers for you. Puscast is a review of the infectious disease literature for the last 2 weeks that I found interesting or entertaining. So on to the literature, shall we? In our viral section, remember to listen to This Week in Virology. You can catch Daniel in those clinical updates. The first paper I've pulled is from JAMA, Antiretroviral Drugs for Treatment and Prevention of HIV in Adults, 2024 Recommendations of the International Antiviral Society USA Panel. So this document is updated every 2 years. I'm guessing we probably talked about it last time. Some of the changes since the 2022 guidelines include sections on ART recommendations during pregnancy, management of virologic failure, switching in patients with virologic suppression, and long-acting agents. So for pregnancy, dolutegravir with tenofovir alafenamide and emtricitabine remains preferred. The panel does now recommend bictegravir, I'm just going to say TAF, tenofovir alafenamide, emtricitabine, or Biktarvy as an alternative, which does provide pregnant people with a simplified single tablet option listed in the guideline. There's a new box on the potential of using dolutegravir with tenofovir emtricitabine or bictegravir and TAF emtricitabine, regardless of underlying NRTI resistance, when the INSTI remains fully active. So the goal here to simplify switch strategies for patients who remain on multi-class complex regimens. So consideration of a second-gen INSTI with a booster protease inhibitor has been omitted, although that does still remain an option for those who it may not be best to use an NRTI. The panel still points out the long-acting cabotegravir rilpivirine for those with virologic suppression, as well as supporting use for select patients with viremia and adherence challenges with oral ART. They actually recommend referring patients with viremia and adherence challenges to studies of long-acting agents. There are some other changes, such as a section on cancer, so like anal cancer screening, although there's no specific guidance here. The cardiovascular risk section was expanded after the Reprieve trial, which showed a 1/3 risk reduction in major adverse cardiovascular events in people living with HIV who had no other indication for a statin at baseline. There are also new data on dosing for INSTIs in the setting of LTBI treatment. So lots of things in there, just pulling out a couple pieces that had changed, and you can pull that up and download and get that on your computer. Next, I pulled a report from MMWR, Notes from the Field, Human Parvovirus B19 Infections Among Pregnant Persons, Minnesota, January through September 2024. This report noted the increased frequency of parvo B19 infections, including those with severe sequelae, in pregnant women in Minnesota. So there were 5 cases among women aged 20 to 40. They were in the range of 13 to 20 weeks gestation and evaluated during the May to August 2024 window. The women had no known epidemiologic links. Diagnosis was confirmed by IgM or PCR testing, including 3 women who received positive parvovirus B19 PCR amniotic fluid test results. 1 patient had fetal hydrops and experienced fetal demise at 20 weeks before fetal transfusion could be performed. 1 had no complications, and the 3 others required fetal transfusions, but all of those latter children were born without complications. So this alert was meant to serve to share as a reminder, especially for obstetric providers with a high risk of high index of suspicion to test. So for pregnant persons, that would be serology and PCR, and thinking about it, if they've had known exposure to B19 or compatible signs and symptoms, I think for me, I would particularly think about it in those who have younger siblings who might be ill or have had parvo B19 circulating at school. And then our last viral article that I have for you today is from the Journal of Heart and Lung Transplantation. Maribavir for refractory cytomegalovirus, or CMV, infection, with or without resistance, in solid organ transplant recipients. Subgroup analysis of the Phase 3 randomized Solstice study. So maribavir was approved back in 2021 based on the findings from that Phase 3 Solstice RCT, which found that maribavir was superior to investigator-assigned therapy. So that could have been ganciclovir, valganciclovir, foscarnet, or cidofovir, for the primary endpoint of CMV viremia clearance at week 8. So the results were 55.7% for maribavir versus the 23.9% for investigator-assigned therapy. These were in hematopoietic stem cell transplant patients or solid organ transplant recipients with relapsed refractory CMV. The results also showed fewer treatment discontinuations, and so this paper adds some additional efficacy and safety data for the SOT subgroup. The main take-home is that it's quite similar to the overall population. There was a higher proportion of maribavir-treated patients achieving the primary endpoint, so 55.6% versus 26.1%, and there were fewer discontinuations due to treatment-emergent adverse events, 3.5%. There were no graft losses. Patients in both arms experienced acute rejection. Maribavir, that was 6.3%, and the other therapies was 5.8%. And then the other question that sometimes comes up, treatment-emergent maribavir mutations occurred in 28.2% of patients, and 19 of 33 patients achieved viremia clearance with subsequent alternative treatment. So this incident was also similar to the overall study population as well. All right, we'll move into our bacterial section. You can be sure to listen to This Week in Microbiology on microbe.tv. The first one I have here is from CID, Choosing Wisely, Effectiveness and Safety of Antibiotic Prophylaxis in Close Contacts of Invasive Group A Streptococci Infection. And so I'm just going to, it's actually directly from the paper. Based on biological plausibility and expert opinion, public health guidelines, such as those in the U.S., recommend the use of antibiotic prophylaxis among all close contacts of people with invasive group A strep, mainly confirmed severe cases, so things like necrotizing skin soft tissue infection, meningitis, or other conditions resulting in death. The authors here use commercial and Medicare claims data from the U.S. to try and evaluate effectiveness and unintended harm of antibiotic prophylaxis in preventing infection in families within 30 days of the initial index invasive group A strep case. So basically ICD-9, ICD-10 codes, notes, and labs, and so on. So close contacts were family members enrolled under a single health plan. They use antibiotic prophylaxis within 7 days of an index infection, finding dispense of cephalosporins, macrolides, penicillin, or clindamycin. The author summarized 21,000 close contacts of about 17,000 index cases, and found an incidence of 13.2 per 1,000 person years of group A strep infection in close contacts who received prophylactic antibiotics versus 14.8 per 1,000 person years in those who did not. So there was no clear difference in group A strep invasive infection among the two groups who did or did not get prophylaxis in the multivariate logistic regression, so adjusting for sex, age, comorbidity, steroid use, and recent infection. They did find a threefold increase in adverse drug events reported. So the authors here are advocating for close maintenance and education for family members, but perhaps we can tailor our guidelines a bit more given the risk of unintended harm. So, curious what people think. There has also previously been a systematic review that also didn't show much, I'll say scant evidence of the benefit risk balance of antibiotics in preventing subsequent group A strep, but just something to think about and steps away from things that we have been recommended before. And the other bacterial paper I have today, I pulled because I know there's been lots of reports and folks that have been seeing mycoplasma in their communities, particularly our pediatricians. So in JPIDS, they had a publication, Resurgence of Pediatric Mycoplasma Pneumoniae Infections in Southeast Texas, November 2023 to June 2024. Authors here conducted a retrospective review of children tested for Mycoplasma pneumoniae from January 2020 to June 2024, and they found the M. pneumoniae PCR positivity increased starting in November 2023. For them, it peaked at 18.3% in June 2024. So this is the Texas Children's Network, which included a wide variety of sites throughout Southeast Texas. In this window, there were 81 confirmed cases, including 60 children with respiratory illness and 16 with reactive infectious mucocutaneous eruption, or RIME. 68% of children with lab-confirmed respiratory infection were hospitalized. 71% of those required supplemental oxygen. I thought it was interesting to see, in particular, the high incidence of RIME in this group. But, I think the CDC has also been noting on their website and communications about how the mycoplasma discharge diagnosis data from March through October has showed increase among all age groups. This is particularly important, though, because the increase is highest among children, especially those aged 2 to 4, which, for pediatricians and pediatric ID docs, I think is notable. We don't tend to think of that as a leading cause of pneumonia in that age group. So we'll keep an eye on this, and I think when people have other information, I'll bring that in some future podcast episodes. All right, on to our fungal section. I have two papers from our fungal friends. So the first one is from Transplant Infectious Diseases, Alternative Pneumocystis Pneumonia Prophylaxis in Solid Organ Transplants. I have to give a shout out to the first author, Kevin, who I did get to catch up with at ID Week. So this is a single center retrospective cohort study looking at the use of alternative pneumocystis, or I'm going to say PJP prophylaxis, use in adult SOT recipients. These were transplanted in the 2020 to 2022 window. They found that a third, or 34.9%, of 953 solid organ transplant recipients had received alternative PJP prophylaxis, aka non-Bacterial, non-trimethoprim sulfa. This was basically all atovaquone, but there were a few, about 4%, who received dapsone instead. 22.8% were placed on alternative therapy without ever starting trim-sulfa, mostly due to a sulfa allergy. I think that was like 80% of them. In patients who did start trim-sulfa and were switched, the switch regions identified were mostly hyperkalemia, so that was 40%, and then leukopenia in 30%. Although 80% of the patients had resolution of those side effects, only 27.3% resumed trimsulfa. And then the other part of this is that of the patients who did reinitiate the Bacterial, 86% tolerated it and did okay. So they did find one case of breakthrough toxo and one case of nocardia, no cases of PJP, and they give a little bit of context for those cases. I thought this was a great overview of a very common challenge that we face, I think, throughout ID, but in particular in transplant. And just a reminder to retrial trimsulfa when you are able to, or to advocate for that when you can. And the other fungal paper I have is from the Lancet Infectious Diseases, Mortality in Chronic Pulmonary Aspergillosis, a Systematic Review and Individual Patient Data Meta-Analysis. I am taking this as a nice opportunity to think about chronic pulmonary aspergillosis, which is a little bit different than what we're typically seeing in those invasive aspergillosis cases. I also selfishly do a lecture on this, so this is a good update and something that I need to do and make sure I update on my slides there. There are several subtypes of aspergillosis. The most common, of chronic pulmonary aspergillosis. The most common is the chronic cavitary pulmonary aspergillosis, CCPA, while chronic fibrosing pulmonary aspergillosis is sort of a severe end-stage disease manifestation. The clinical course can be quite variable and includes some rapidly progressive infection. It can cause really extensive lung fibrosis and potentially death. And I have thought, and the way I teach it is that it helps to think about the subtypes on a spectrum that have, overlapping presentations and the ability to progress or regress between the subtypes during a disease course or even while they're on antifungal therapy. So rather sort of classically being a host defense issue and thinking about invasive aspergillosis, chronic pulmonary aspergillosis is happening generally when there's like a structural damage. So maybe you have a cavitary disease like previously treated tuberculosis or in the setting of cancer. So that was just a little background. This literature review found that the 1-year mortality of chronic pulmonary aspergillosis after diagnosis was lower in patients with post-TB lung disease at 7%, in contrast to those who had other different comorbidities. So interstitial lung disease, 18%, malignancy, 17%, COPD, 16%, NTM, 11%. And then the mortality in general in the subsequent years was lower across all the groups. They did find that age over 60, subacute invasive aspergillosis or chronic cavitary pulmonary aspergillosis subtypes, and underlying malignancy were the most important identifiable adverse prognostic factors predicting mortality in patients with chronic pulmonary aspergillosis. So I brought this up because I think that sometimes people think about the CPA, the chronic version, as almost more benign, but I think this is a good reminder that it's not. And even though it is less lethal than the invasive aspergillosis, this is a pretty significant and notable morbidity and mortality. So in that first year, a mortality of about 15-ish%, and only about 2/3 of patients are surviving to 5 years. And I did just put an image from the Kaplan-Meier curves, which I think was figure 2. But anyways, just a great summary and a reminder to think about aspergillosis infection and other settings and than what we classically see. All right. For our parasitic section, make sure to listen to This Week in Parasitism. I have one article from MMWR, Waterborne Disease Outbreaks Associated with Splash Pads, U.S. 1997 to 2022. So splash pads, for those who don't know, I liked their definition. Recreational, interactive water venues that spray or jet water on users. These are usually for children under 5. things like water playgrounds and fountains and so on. These were first found to be associated with waterborne disease outbreaks in 1997. In the time frame here, though, through 2022, there have been 60 waterborne disease outbreaks associated with splash pads, leading to over 10,000 cases and 152 hospitalizations. I know it is the dead of winter in US, and you might not be thinking about splash pads, or maybe it's the opposite, and you're like specifically dreaming of beaches and warmer weather during the cold. But 2/3 of outbreaks, as a reminder, are caused at least in part or largely by Cryptosporidium. And that is important to note that Crypto is tolerant of chlorine, which is usually that sort of primary barrier for pathogen transmission in splash pad water. So I put this in the parasitic section because that's my take home, is don't forget about Crypto and things like splash pads and asking about that. But some of the other bugs that have been reported in outbreaks have included Shigella, E. coli 0157, Campylobacter jejuni, Giardia, and norovirus. But even some of those bugs were sort of overlapping outbreaks with Crypto. So you can check out the outbreaks by state in Figure 1, which appropriately is various shades of brown. I'm not sure if that was intentional or not, but you can see most of the cases particularly highlight Florida and Ohio there. And I did residency in Ohio and remember asking about these types of interactive water places when kids came in with diarrhea. So just a reminder, particularly once we get out of the winter season. All right, and then I'll close this out with one miscellaneous paper from OFID, Skin Color Representation in Infectious Disease Textbooks. The authors here took 4 ID textbooks, so Mandel and Bennett's, Manson's Tropical Diseases, Comprehensive Review of ID, and Netter's ID, and they examined the teaching images based on skin color depiction and on if the conditions being indicated were socially stigmatized, so if linked to sexually transmitted infections, IV drug use, poverty, incarceration. They, not surprisingly, found skin color underrepresented variety, which affirms other recently published work, and I think we maybe have mentioned this on Puscast, I'm not sure. But while this is hopefully a call to action for the publishers, I think what is helpful is thinking about some other efforts that have been in place to try to help with that, because I think many of us are often learning from online resources anyways. So there are some organizations or homegrown databases that you could check out. So I pulled a couple that are actually listed in the paper. So if you can't remember what I say, you can go pull the paper. Skin of Color Society, Brown Skin Matters, which is on Instagram, and then some other major databases like Visual Diagnosis, if you have access to. They have clinical findings on various skin colors, as well as some resources from the American Academy of Family Physicians and the Journal of American Academy of Dermatology and others. All right, so that brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire. You can find the Infectious Disease Puscast at Apple Podcast, microbe.tv/Puscast, or grab it with your favorite podcatcher. We love to get your questions, comments, and paper suggestions. You can send those to puscast@microbe.tv. If you like what we do or want us to keep doing it, please consider supporting the science shows of Microbe TV at microbe.tv/contribute or Parasites Without Borders at parasiteswithoutborders.com and click on the donate button. I'm Sara Dong. You can find me at Sara Win Dong or at Febrile Podcast on Blue Sky or at febrilepodcast.com. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye. Thanks for listening. We'll be back in 2 weeks. Another podcast is infectious.